Welcome to the Deep Dive. Today we're tackling a really fascinating and pretty intricate area of modern medicine. We're talking about surgical techniques for when blood vessels need to be, well, cut and then put back together during cancer surgery. Just think about that surgeons aren't just removing tumors, they're also expertly managing, the critical infrastructure of our circulatory system.
It really does. It highlights just how far surgical oncology and vascular surgery have come together. To guide us, we're drawing from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. It's a top textbook in the field.
Yeah, a really solid source.
Gives us a great foundation of expert insights.
Exactly. So our mission today, which you've already accepted by tuning in, is to understand when and why these complex operations are actually necessary in the fight against cancer. We'll explore the techniques and, crucially, what it all means for the patients undergoing these procedures. We're aiming for clarity here, not a blizzard of medical jargon, just the essential principles and maybe some surprising facts along the way. Okay, let's unpack this, starting with a particularly challenging group, pancreatic malignancies.
Pancreatic cancer. Yeah, unfortunately, it remains a major challenge. The statistics are quite stark.
They really are.
It's a leading cause of cancer deaths, and the 5-year survival rate is still, disappointingly low. Often, surgery to remove the tumor resection, as we call it, is a really vital part of improving long-term survival, usually within a bigger treatment picture.
And this is where it gets really interesting, right? Because not all pancreatic cancers are, suitable for surgery in quite the same way. We talk about resectability. Can you maybe break down those classifications for us?
Sure. Resectability is generally put into 3 buckets: unresectable, borderline resectable, and resectable. And a key factor, maybe the key factor, is whether the tumor involves nearby blood vessels. So, for instance, if the tumor has really grown around major arteries like the superior mesenteric artery, the SMA, or the hepatic arteries to a point where safe reconstruction seems unlikely, that's usually considered unresectable.
Okay.
Same goes for the veins, really. If there aren't good options for repairing or replacing affected veins, that likely puts it in the unresectable category too.
Got it. So what about that middle ground then, borderline resectable? What puts a tumor in that more ambiguous zone?
Right, borderline. That often means there's a significant interface between the tumor and the superior mesenteric vein, the SMV or the portal vein. We might be looking at the tumor touching or wrapping around, say, 180 degrees, or maybe even more of the vessel wall. Or there could be a blockage in these veins, but one that might still be reconstructible.
Okay, so there's some involvement, but maybe not complete encasement yet.
Exactly. For arteries like the SMA or the celiac artery, involvement of less than 180 degrees might still fall into borderline. And interestingly, newer guidelines are also looking at other factors, like very high levels of a tumor marker, CA 19-9 over 500.
Okay.
And also the patient's overall functional status using the ECOG performance scale. An ECOG status of 2 or more, meaning it's noticeably impacting daily activities, that can also push it towards a borderline classification now.
That's fascinating how it's not just about the vessel contact, but these other factors too. So if a tumor is borderline, what's the next step? That vascular involvement still sounds like a pretty big hurdle.
It absolutely is, and this is where neoadjuvant therapy, so chemo, sometimes radiation, given before surgery, can be really valuable.
Right, to try and shrink it away from the vessels.
Precisely. The goal is to shrink the tumor, reduce its interaction with the blood vessels, and hopefully make it more amenable to a clean surgical removal. But if there's still significant vascular involvement after that initial treatment, then vascular resection and reconstruction during the pancreatectomy becomes, necessary.
It just sounds risky, though. Cutting out and repairing major blood vessels, does that seriously increase the complication risk?
Well, the data does suggest, yes, a higher chance of major complications when vascular reconstruction is involved. However, and this is important, the mortality rates don't necessarily differ compared to a standard pancreatectomy, assuming patients are selected properly.
Okay, that's crucial.
And what's really key here is that for patients with this borderline resectable disease, this complex approach often represents their only potential path to a cure. Studies have actually shown survival rates after pancreatectomy with vascular resection are pretty comparable to standard pancreatectomy for initially resectable tumors, and significantly better than for patients whose tumors are just deemed unresectable. So, to boil it down, for these challenging borderline tumors, adding this complex vascular surgery doesn't seem to worsen long-term odds compared to standard surgery for less advanced cases, but it gives them a shot at a cure they wouldn't otherwise have. That's That's pretty powerful when you think about it.
That really is a powerful point. Yeah, increased immediate risk, perhaps, but the potential for a life-saving outcome.
Yeah.
Now, I remember reading about something called the artery-first approach. What's the basic idea behind that technique?
The artery-first approach. It's a technique often considered when you anticipate needing a venous resection and reconstruction during a pancreatic head surgery, like a Whipple procedure. The basic idea is to first carefully dissect and tie off all the small branches of the superior mesenteric artery that supply the pancreas, along with the surrounding tissue, before you even really tackle the SMV or portal vein.
Okay, so deal with the arterial supply first.
Exactly. By ligating those arterial branches, you effectively devascularize the tumor bed in that specific area. This makes the later dissection and handling of the veins less prone to bleeding, allowing for a cleaner, more controlled removal of the whole tumor block.
Okay, you're essentially clearing the arterial landscape first to make the venous part easier and safer. What are the main benefits of that?
Well, several potential advantages. Like we said, it can lead to significantly lower blood loss. It can also make the en-bloc resection, removing everything as one unit, technically a bit easier. And it increases the mobility of the surgical specimen, which then can simplify the venous resection and reconstruction that follows. This often involves mobilizing the right colon quite extensively to get good exposure, and then meticulously dissecting along the SMA right from its origin.
Makes sense. Create better access, minimize bleeding early on. Now, when surgeons are looking at the veins, the SMV and PV, how do they actually tell if there's real tumor invasion that means they have to resect? Imaging must be critical here.
Absolutely critical. High-quality preoperative imaging, like detailed CT scans, with contrast timed just right. The portal venous phase is essential. There are several signs on the scans that wave a red flag for potential invasion.
Like what?
Things like the absence of a normal fat plane that clears separation between the tumor and the vessel, or if the length of tumor contact is more than 5 millimeters along the vessel wall, or the presence of venous occlusion, blockage, with collateral vessels developing alternative routes for blood flow. Also, something called a teardrop sign in the SMV, suggesting the vein is being pulled or tethered by the tumor.
A teardrop sign. Okay.
And, of course, any obvious irregularity in the wall of the blood vessel itself.
Those are very specific indicators. And you mentioned that 180-degree rule earlier regarding unresectability. How does that play in here?
Exactly. If the imaging suggests the tumor encircles a vein by more than 180 degrees, that's a strong indicator of likely unresectability. It implies a very high chance of complete encasement, making a safe resection and reconstruction extremely difficult, if not impossible.
Okay, so let's say the surgeon decides, yes, a venous resection is necessary. What are the different ways they can put things back together? What techniques are available?
There's actually a spectrum of techniques, and it depends on how much of the vein needs to come out. For more limited involvement, maybe just a small slice, a tangential resection might work. You remove a small piece of the SMV or PV wall and then repair the hole. That repair could be just with stitches, or sometimes using a patch, often a piece of saphenous vein from the leg.
Okay, like patching a tire almost.
Sort of, yeah. For more significant involvement, though, you do a segmental resection. A whole section of the vein is removed. Now, if the remaining ends can be brought together without tension, a primary anastomosis sewing them directly end to end is preferred. That generally gives the best long-term patency, good blood flow, especially if the removed piece is less than about 3 centimeters.
And if the gap's too big for that direct connection, what then?
Then you need an interposition graft, basically using a segment of another blood vessel to bridge the gap. Several options here. Autologous veins from the patient's own body are usually the first choice. Common ones are the left renal vein, the internal jugular vein from the neck, sometimes even a piece of the splenic vein. Each has pros and cons regarding size match, where it is, potential impact of taking it.
Right.
And interestingly, while the saphenous vein works well for those patches we mentioned, it's not usually considered ideal as a main conduit graft, often due to size mismatch or wall thickness issues.
That's a useful distinction. So once the vein is reconstructed, what are the key things surgeons watch for afterwards in the post-op period?
Well, interestingly, there isn't one single standard protocol for giving blood thinners after these surgeries. Generally, patients don't routinely get anticoagulants like heparin, but antiplatelet therapy like aspirin is pretty common. Ultrasound, specifically Doppler ultrasound, a couple of days after surgery is really helpful to check for early signs of blood clots, thrombosis in that repaired vein.
And if they find a clot?
Then further anticoagulation might be started. It's worth noting the risk of thrombosis can vary a bit depending on the type of repair. Direct anastomosis usually has the lowest rates, while using a graft might carry a slightly higher risk.
Okay, and the really crucial question, how does all this aggressive surgery, including cutting out veins, affect the long-term cancer outcomes? Does it actually help people live longer?
The evidence is actually quite encouraging. In carefully selected patients, the long-term cancer outcomes after a pancreatectomy with venous resection seem to be similar to those who just have the pancreatectomy alone.
Really? That's surprising.
Yeah, several studies and even meta-analyses pooling data from multiple studies have supported this. They show no significant difference in immediate surgical risks, mortality or on-surgery time, or even 5-year survival rates between patients who needed the venous resection and those who didn't.
That's a very significant finding. Okay, we've talked a lot about veins. What about arteries? You mentioned earlier that arterial involvement often meant unresectable. Has that view changed at all?
Historically, yes. Arterial resection during pancreatectomy was seen as very high risk, lots of potential complications. However, in situations where the tumor directly involves arteries like the SMA, celiac, or hepatic artery, doing a pancreatectomy that includes removing and reconstructing that artery might be the only way to achieve a complete microscopic cancer removal, that R0 resection we keep talking about.
So it is being done sometimes.
It is, but it's still quite controversial. While smaller case series from very specialized centers show it can be technically feasible and relatively safe in experienced hands, the clear long-term oncologic benefit is still actively devoided. Techniques like, say, transposing the splenic artery to replace a damaged hepatic artery have been used. But it's important to remember, even if you achieve an R0 resection with arterial work, the risk of the cancer coming back can still be pretty significant.
Right. And there's a specific procedure I read about the celiac axis resection, sometimes called the Applebee procedure. When does that come into play?
Oh, the Applebee. Yes, that's a very specific, quite extensive operation. It's reserved for tumors in the body of the pancreas that have grown into the celiac axis itself. That's a major artery supplying the liver, spleen, stomach.
Critical stuff.
Absolutely. The procedure only really becomes an option if there's good collateral blood flow through another artery, the gastroduodenal artery, or GDA, which can then take over supplying blood to the liver once the celiac axis is removed. Surgeons have to very carefully check if this alternative supply is adequate before committing to the Applebee, often using tests right there during the surgery, like feeling the pulse and using Doppler ultrasound.
So assuming that collateral flow is good enough, what does the Applebee actually involve removing?
It involves an en-bloc resection, taking out the common hepatic artery, the celiac artery itself, and the splenic artery altogether, and along with that usually goes the tail of the pancreas and the spleen. It's a major undertaking, really highlights the lengths surgeons might go to in very specific, carefully chosen cases for a shot at completely removing the tumor when other options are off the table.
Truly remarkable surgery. Okay, let's shift gears a bit now. Let's talk about another area where vascular involvement is a big challenge. Hepatic and biliary malignancies, liver and bile duct cancers.
Right. In liver and bile duct cancers, achieving that surgical resection with clean edges, that R0 resection, again offers the best chance for cure and long-term survival. Historically, much like with pancreas cancer, if a tumor had invaded major blood vessels, it was often seen as a major contraindication, frequently meaning surgery wasn't even considered.
But that's also changing here too, isn't it? Particularly for certain types of these cancers.
Yes, definitely. Especially with cholangiocarcinoma, also known as Klatskin tumors. These cancers start right where the bile ducts inside the liver join together, and they have this nasty habit of infiltrating the surrounding vascular structures, the portal vein, hepatic arteries, even sometimes the inferior vena cava, the IVC.
So they grow right into the plumbing, basically.
Pretty much. This infiltrative growth pattern makes getting those negative surgical margins incredibly difficult.
So for these Klatskin tumors, what degree of vascular involvement typically makes them unresectable?
The resectability criteria look at both how far the tumor has spread along the bile ducts and the extent of vascular involvement. For example, if the tumor is spread up the bile ducts into both sides of the liver, or if it's spread on one side plus involves the major blood vessels on the opposite side, that would usually be considered unresectable. Even when it seems technically possible to remove the tumor, its closeness to these major vessels often means surgeons have to perform perihepatic vascular reconstruction, repairing or replacing vessels around the liver just to get those crucial negative margins.
And you mentioned these combined liver and vascular resections carry higher risks.
They do, yes. These are highly complex procedures. They're associated with higher rates of complications and mortality, which is why they really need to be done at specialized high-volume centers. You need a multidisciplinary team with deep experience in both the surgery itself and managing these patients afterwards.
Planning beforehand must be absolutely critical then. What are the key things surgeons are thinking about before they even go into the operating room?
Oh, extensive preoperative planning is paramount. Absolutely essential. This means very detailed imaging CT, MRI, to precisely map out how far the vessels are involved, spot any unusual patient anatomy, and really understand the relationship between the tumor, the bile ducts, and the blood vessels.
Like creating a 3D roadmap.
Exactly. It's also crucial to ensure there's enough healthy vessel above and below the tumor to allow for safe clamping and then rejoining the anastomosis. Plus, you have to carefully calculate the future liver remnant, the amount of liver that will be left behind, if it looks like it might be too small.
Which can happen with big liver resections.
Right. Then techniques like portal vein embolization might be used weeks before the main surgery. That involves blocking blood flow to the part of the liver being removed, encouraging the remaining part to grow bigger to compensate.
Clever. Okay, let's dive into the specific reconstructions in liver surgery, starting with the portal vein. You said that's commonly involved.
Yes, portal vein resection is the most common vascular resection done for hilar cholangiocarcinoma. It's often needed just to get those clear microscopic margins. And interestingly, studies show that even when the portal vein looks clear during the operation, a significant number of cases actually have microscopic cancer invasion found later under the microscope.
Wow, so you can't always trust what you see.
Not entirely, which is why an en-bloc portal vein resection, removing the vein section along with the tumor, is often recommended if there's any suspicion of involvement near where the portal vein branches.
And when they do resect the portal vein, how is it put back together?
Well, the preferred method, if possible, is always a direct connection, sewing the remaining ends of the portal vein directly together, primary anastomosis. This often requires really mobilizing the portal vein, sometimes freeing it up all the way down towards the pancreas. For right-sided liver resections, you usually need about 0.8 to 1.0 centimeter of the main portal vein before it branches to get a safe connection to the left branch.
And if a direct connection just isn't possible, maybe the gap is too long.
Then grafts are used to bridge that gap. Again, veins taken from the patient's own body, autologous veins are preferred. Things like the left renal vein, femoral vein, jugular vein, even a vein from the resected part of the liver itself can sometimes be used. Synthetic grafts are generally avoided if possible, mainly because of a higher risk of infection and clots in this particular setting.
Makes sense.
Ultimately, long-term survival after a liver resection involving the portal vein really hinges on achieving those cancer-free surgical margins. And thankfully, the risks associated with these complex surgeries have been coming down in recent years with improved techniques and experience.
Okay, what about the hepatic artery? That seems even more critical, supplying oxygenated blood to the liver.
Yeah, data on hepatic artery reconstruction here is a bit more limited compared to the portal vein. However, we're seeing a growing number of reports of successful outcomes with combined liver resection and reconstruction of both the portal vein and the hepatic artery, again, in carefully selected patients. Often, when the hepatic artery needs resection, it's involved right at its branching point and frequently requires a portal vein resection at the same time.
So it's often a double reconstruction.
It can be. Knowing the patient's specific arterial anatomy beforehand is absolutely crucial, especially if you might need native vessels for the reconstruction. Similar to the portal vein, ensuring you have enough healthy vessel to clamp and having suitable graft options ready is essential. The great saphenous vein from the leg is often the go-to graft here.
And how have the outcomes been for hepatic artery resection? You mentioned it was historically very risky.
It was. Early experiences had very high mortality rates, but more recent results from highly experienced centers, like the series published by Nagino and colleagues in Japan, show much more acceptable mortality and actually promising survival in well-chosen patients. They even report a significant number of cases where they could achieve a direct end-to-end connection of the hepatic artery using advanced microsurgical techniques.
That's quite a turnaround, a real testament to specialized centers. And finally, what about the IVC, the inferior vena cava? That sounds like a massive vessel to tackle.
Oh, absolutely. Involvement of the IVC has historically been a major reason why these cancers were considered inoperable, just because the outcomes were so poor. But again, with advancements in surgical techniques, perioperative care, it's now considered resectable in highly selected patients with acceptable risks.
How do they reconstruct something that big?
Well, it depends on how much is involved. For small defects, maybe a direct repair or a patch using a special clamp to maintain flow might work. For more extensive involvement, the affected segment might need complete replacement with a graft, either synthetic, like PTFE, or maybe made from biologic materials. In situations where infection is a big concern, grafts made from the patient's own veins, sometimes cleverly fashioned into a spiral to get the right diameter, might be used.
A spiral vein graft, wow.
Yeah, and giving blood thinners like heparin during the surgery itself is standard practice when working on the IVC. Now, IVC resection and reconstruction definitely still carries a higher risk compared to other vascular work around the liver, but results from experienced centers, like the series by Hemming and colleagues, show it can offer a survival benefit in carefully chosen patients. But these are absolutely procedures that should only be done at highly specialized centers with expertise in complex liver surgery, transplantation, and all the support that goes with it.
Absolutely fascinating, really pushing the boundaries of what's surgically possible. Okay, let's move on to a different type of cancer now, where vascular considerations are also vital. Soft tissue sarcoma.
Right, soft tissue sarcomas. They're a rare and quite diverse group of cancers arising from connective tissues anywhere in the body. Arms and legs are the most common sites. The mainstay of treatment, the only potentially curative approach, is complete surgical removal with a clear margin of healthy tissue all around that wide, microscopically negative resection. Historically, for sarcomas in the limbs, amputation was often seen as the most reliable way to get local control.
But the standard of care has shifted dramatically towards saving the limb whenever possible, right?
It really has. Key studies showed that limb-sparing surgery combined with radiation therapy afterwards offers similar long-term cancer control to amputation, but with obviously much better functional outcomes for the patient.
Makes sense.
However, saving the limb often means you have to resect and reconstruct major blood vessels if they're involved by the tumor. And this requires really careful preoperative planning and a collaborative approach, surgical oncologists and vascular surgeons working closely together.
So what are some of the key things they need to consider when planning surgery for a sarcoma involving blood vessels?
Well, it starts with standard staging, understanding the cancer's extent. Then a multidisciplinary team discussion is crucial: surgeons, oncologists, radiologists, pathologists. Detailed vascular imaging, like CT or MRI angiography, is essential. It shows exactly which vessels are involved, how blood flow might have already adapted through collateral pathways, and if there are any clots present. MRI is particularly good for seeing the tumor's relationship to nearby soft tissues around the vessels.
Okay.
Before the surgery, the team also plans exactly how they'll get access to the vessels, how they'll control blood flow above and below the tumor area, maybe using vessel loops or clamps, whether any catheter-based techniques might help, and the specific plan for reconstructing any vessels that need to be removed.
And what materials do they typically use for these reconstructions in sarcoma surgery? Is it similar to the other cancers?
There's a range of options, yes. Autologous veins the patients own are often preferred. The great saphenous vein, GSV, from the leg is a workhorse. But femoral vein, splenic, jugular, renal veins can also be options depending on the need. Beyond that, you have preserved vessels from deceased donors, cadaveric grafts, materials from animals like bovine pericardium, and of course synthetic materials like PTFE or dacrin.
Okay. Let's talk specifically about arteries in the arms or legs involved by sarcoma. You remove one, you have to replace it, right?
That's correct. Arterial resection requires reconstruction, always, to prevent ischemia, lack of blood flow to the limb. Now, if the tumor only involves a small part of the artery wall, say less than half the circumference, maybe a patch repair patch angioplasty using vein or another material is enough. But if the involvement is more extensive, then a formal bypass graft is needed, connecting a new vessel above and below the removed or blocked section.
And what's usually used for that bypass?
The great saphenous vein, the GSV, is generally the preferred conduit, often taken from the opposite leg if possible, to avoid worsening any swelling in the operated limb. Studies generally show that using the patient's own vein leads to better long-term patency. The graft stays open longer compared to synthetic grafts in this setting. And the good news is, limb salvage rates, even when vascular reconstruction is needed for extremity sarcomas, are generally very high, often over 90%.
That's fantastic.
Yeah. Though complications can happen: infection, wound breakdown, swelling, edema, blood collections, hematoma, clots, thrombosis. But the long-term function of the reconstructed arteries is usually quite good.
Okay. What about the veins in the arms or legs involved by sarcoma? If they need to be removed, do they always need reconstruction too?
Managing veins here is a bit less definitive, a bit more debated. If the veins have been blocked for a while, chronic occlusion, or are in less critical parts of the surgical field, they can often just be tied off ligated without causing major problems, especially if there's good collateral drainage, other veins picking up the slack.
So the body is already adapted.
Exactly. The decision to reconstruct major veins is more nuanced. Some surgeons feel it adds minimal risk and might help prevent excessive postoperative swelling or venous hypertension. Others point out that vein reconstructions in this setting can have a higher rate of clotting off later, and that swelling can often be managed effectively with compression therapy and elevating the limb. Also, if a tissue flap is used for wound coverage, new veins often grow into that flap over time, potentially making the original venous reconstruction less critical in the long run. So, while reconstructing major veins is definitely an option, it's not always considered absolutely essential in every single case.
Interesting difference between arteries and veins there. What about sarcomas in that really tough spot, the retroperitoneum behind the abdominal organs? Vascular involvement there must present unique challenges.
Oh, absolutely unique and significant challenges. Retroperitoneal sarcomas are particularly difficult because they're right next to the biggest vessels, the aorta and the IVC, plus other vital organs. Often getting a complete resection requires removing multiple organs along with the tumor multivisceral resections just to achieve those negative margins.
Wow.
And when the aorta or IVC are directly involved by the tumor, removing them becomes necessary for any chance of a cure. This adds a huge layer of complexity. Planning for these cases has to meticulously assess not just the vascular involvement, but also which organs are involved. Because you might be working on the aorta or IVC, the team needs to consider maybe needing cardiopulmonary bypass or veno-venous bypass during the operation. And if kidney vessels are involved, the risk of needing dialysis afterwards needs careful evaluation too.
And how are the aorta and IVC usually reconstructed in these big retroperitoneal cases?
Given their large size, synthetic grafts, PTFE or Dacron, are often the first choice for reconstructing the aorta and IVC. They avoid having to harvest large veins from elsewhere and make diameter matching easier. However, if there's a high risk of infection, some centers might opt for autologous tissues, maybe fashion grafts. And if reconstructing the IVC seems too risky or difficult, ligation tying it off might be considered, but usually only if there's good evidence it was already blocked before surgery or that there are excellent collateral pathways.
Right, the body needs a way for blood to get back.
Precisely. The complication rates after these massive retroperitoneal sarcoma surgeries involving major vessels can be higher, understandably, given the scale of the operation. But the long-term patency rates for the reconstructed aorta and IVC are generally pretty good. Ultimately, though, the patient's long-term outcome heavily depends on achieving that complete R0 resection, getting all the tumor out with clean margins.
So as we kind of wrap up and look across all these different cancer types, pancreatic, liver biliary, soft tissue sarcoma, what are some of the big picture themes or key takeaways about vascular resection and reconstruction?
Well, I think a key theme is that the surgical removal and repair of major veins, the portal vein, the SMV, the IVC, is increasingly safe and feasible in carefully selected patients across these diverse cancers. These techniques are really crucial tools that allow for higher rates of achieving that complete tumor removal, that R0 resection.
Which is often the goal for cure.
Exactly. Arterial resection and reconstruction, well, that remains more technically demanding, carries more inherent risk, especially in the context of pancreatic and hepatobiliary cancers, but it is being done successfully in specialized high-volume centers. And in soft tissue sarcoma, vascular reconstruction, both arterial and venous, though perhaps venous less definitively, is really fundamental to limb-sparing surgery, offering oncologic outcomes comparable to amputation but with much better function.
This has been an incredibly insightful deep dive. It's truly remarkable, isn't it, to see how surgical techniques have evolved to the point where these major blood vessels can be, well, taken out and meticulously put back together in the fight against cancer.
It really underscores the highly collaborative nature of modern oncology.
Yeah.
You absolutely need close cooperation between surgical oncologists, vascular surgeons, interventional radiologists, diagnostic radiologists providing that critical imaging, medical oncologists, pathologists, the whole team.
Absolutely. It takes a village, as they say.
It really does, especially for these complex cases.
Yeah. It really makes you think about the incredible progress, allowing removal and repair of these vital pathways. It offers a chance at longer life, better quality of life for so many patients who, maybe decades ago would have been told there were no surgical options left. And it really poses an interesting question for the future, doesn't it? What other seemingly insurmountable challenges in medicine might be overcome with this kind of focused innovation and intense collaboration?
That's a powerful thought to end on, absolutely.
Indeed. Well, thank you so much for sharing your insights today. And thank you all for joining us on this deep dive. We'll catch you next time.